Welcome to MOROF. We're so glad that you could be a part of this presentation. We're very excited about our speaker that's coming up. And we all know that when it comes to communicating to people, we're all made a little different. And we all have our own little nuances and psyches, and all of the psychological people get into all sorts of different assessments. And many of you may be familiar with some of those different assessments out there. You know, the DISC program, are you a D, an I, an S, a C, and all the different things that go with that. And Nick is going to be doing a presentation today that kind of covers not necessarily directly with some of those things. It'll kind of augment any of the other maybe information that you've gotten in terms of the psychological part of dealing with physicians. So we're excited to hear about that, but none of this would be possible without, of course, MOROF and without some of our sponsors. And today we have Tom Abissart from Longwood CPA, who is our sponsor for this morning's breakfast. So Tom, you want to come up and tell us a little bit more about your firm and introduce Nick.
Morning, everyone. Before I introduce our speaker this morning, I want to talk a little bit about how we can be each other's colleagues. And I want to talk about the system of support that MOROF offers for every single person in this room. So as you know, we're in a period of really dramatic change in the technological environment and in the regulatory environment, and that has created massive, sometimes crushing challenges for the medical practitioner. Yes, that's true. But it also, there's an opportunity for really significant things that can be done here if we can evolve and adapt. So I keep thinking, when I think of colleagues, I keep thinking of, I get by with a little help from my friends. I wanted to sing that, but I didn't have the guts to do that for you. But we really need good colleagues, and we need to use technology effectively to reduce our burden. And I find, I've said this more than once, that working with my closest colleagues on a day-to-day basis is absolutely my favorite part of public practice. We need each other. Colleagues are people that you can let your hair down with, people who go out of their way to help you in the day. And most importantly to me, colleagues are people that add energy to your life instead of taking it away. So being part of MOROF has enabled me to be part of what I think of as an ecosystem of vetted resources, whether you're a medical practitioner or a business associate. So it's quite an opportunity for us. Together, we can solve almost any problem that any medical practitioner would face. So I want you to think about that. Our speaker today is Nick Hernandez, and he's board certified in healthcare management. He is a fellow of the American College of Healthcare Executives. He has 9 years ago, he founded his company. It's called Abissa, and he specializes in sole practitioner, small group practice management. He has 20 years of experience in operations and leadership. He's a graduate of the U.S. Naval Academy at Annapolis and a former Marine captain. I would welcome you today. Please welcome Nick Hernandez.
Today we're going to talk about physician relationships, and I actually kind of change this up a little bit. I normally give your typical presentation, and but this morning I know it's kind of early and everybody's got to go to work, and I had to drive a little ways. So I turned this up a little bit more into a speech kind of talk thing. Death by PowerPoint is what we're going to see this morning, with hopefully some funny pictures. Hopefully you pick up on some of my comic relief, if I can kind of time it a little bit about right. So let's have fun with this. We're going to talk a little bit about physician relationships, some of the generational differences, kind of an overview. I'm going to stereotype physicians, if you will. Going to talk about how you can then, understanding that, deal with them as a manager or as a vendor, just interacting with physicians, and then also talk about physician recruitment, which is a big issue for both medical practices and healthcare organizations in general. So for starters, let's see if this works here. So physicians are distinct. We have these solo practitioners, and they tend to prize autonomy and authority, whereas members of a small group practice, they tend to put a premium on things such as data and management systems and training. And then in contrast, we have multi-specialty groups, and they have their own traditions and cultures that need to be respected. And lastly, physicians with which a hospital will actually contract, they tend to respond best to vision and charismatic leadership. So understanding the nuances of these different kinds of physicians will help you be able to get better results. So we'll talk a little bit about some of the generational differences now of physicians. First, the traditionalist physicians. They were born around 1945. This generation is trusting and hopeful. They're respectful, and they're very loyal. And you know, before anybody in the audience thinks that that we don't have this generation of physicians actually working today anymore, I beg to differ. I just got through working with a group practice where the senior physician, still practicing, still seeing patients on a daily basis, was 85 years old. And the infamous baby boomer generation. So the baby boomers are challenging, and they're assertive, they're demanding, and they're far more critical. And this should sound familiar because we actually have tons of this generation of physicians practicing today. They're often very influential and in key positions of power. And enter Generation X. Generation X, achieving security is very important to them. These physicians are primarily concerned with how little they have to work, how infrequently they would be on call, how much vacation they would receive, how much money they can earn, and how many additional perks that they can negotiate. But on the flip side, Generation X can be incredibly productive and willing to contribute when they can understand their immediate and successful consequences. So in general, and we're going to stereotype physicians in general, and we'll break it down a little bit, some of the differences, but in general, an overwhelming number of physicians, and let me just stop and say that I didn't get to Generation Y, the millennials, because for the most part, depending on what your year group is that you're looking at, they're actually still in training, so we haven't seen a whole lot of them actually hit the marketplace yet, and it would personally take me a couple of years till we kind of get accustomed to how they are actually as physicians. But in general, an overwhelming number of physicians, they value respect, they value control. Of course, we know that they all want fair reimbursement. They value efficiency and improvements in patient care, and I can't stress this one enough, they value their time, and we're going to come back to that several times this morning. Physicians are supremely self-confident, but they do not listen well. They're quick to interrupt patients, draw conclusions, and act on their initial impressions. Unfortunately, physicians are expected to have all the answers. They bear the ultimate legal responsibility, and they must meet the expectations of perfection. And so when you combine all this together, it's easy to understand why physicians feel that they need to be able to predict and thereby control the environment in which they actually work. So I like to start off by saying that there is no such thing as physicians, note the plural. There's only physicians, singular. So although we can stereotype, dealing with physicians is indeed an actual one-on-one sport. And physicians as a member of expert culture, they're motivated primarily by vision and not by mission. And this is where a lot of hospitals fail as they go to integrate these physician groups. In most medical schools, they encourage rugged individualism, and they actually may in fact select candidates based off of their autonomy and their authority and their rigidity. And medical students and residents are actually not taught how to function as members of a team. Anybody recognize this guy? He's the Unabomber, right? Doesn't work, he works alone. I'm not suggesting physicians are Unabombers, but it's what came to mind. So physician culture is steeped in tradition and built upon an ethic of independent endeavor. And standardization amongst physicians is considered antithetical to that independent culture. And amongst them, a high variation is actually acceptable. Physicians generally are not willing to speak on behalf of their colleagues because they actually would resent their colleagues speaking on behalf of them. We have a lot of cultural barriers to dealing with physicians. When we deal with healthcare and change, things such as we know physicians' resistance to being measured, their need to be perfect, their reluctance to criticize colleagues, as I just mentioned, and their resistance to teamwork. These all reflect a deep-seated belief, that autonomy is key to physician culture and quality. Physicians typically find it very difficult to engage in potentially collaborative type or win-win negotiations because collaboration requires trust, and physicians by nature are predisposed not to trust. A physician is more likely to be attracted for caring for patients in a healthcare setting if their workday is made easier. And as I alluded to earlier, time-wasting efforts frustrate physicians and they make them feel disrespected. Come on, guys, I'm trying. But physicians, they do loathe time stealers and inefficiencies, and any change that you would introduce in a healthcare environment must be one that's easy to try and easier than the status quo to execute, hence the failure of things such as EMR. So let's talk a little bit about the difference between physicians and, let's say, administrators and how they see things. Physicians perceive things linearly, like a train. Physicians have a short time frame of reference, and they act as the patient's advocate. Notice the singular form there. Administrators, on the other hand, they must apply a systems perspective, plan for the long term, and they serve as the patient's, note the plural form, advocate. Physicians have historically seen themselves as their patient's sole advocates, with the rest of the world divided into those who are trying to help and those who are simply in the way. And unfortunately, a temper tantrum in the pursuit of patients' interest was often acceptable behavior. Case in point, here's a study by the American College of Physician Executives where we see that we have a high number of, this is with regards to physicians, physician behavior problems in the past year. It happens daily. A high number of degrading comments and insults, yelling, of course, believe it or not, physical assault on behalf of the physicians. And unfortunately, it goes on year after year after year. And so with studies such as this, it makes you want to say, holy cow. The Joint Commission, or for those who remember, used to be JACO. It got too long, so they decided to shorten it. Probably the only government agency that actually did that. They actually have identified failed communication as the most frequent factor contributing to sentinel events. And although administrators may actually be enthusiastic about an idea that promotes change and saves money in your organization or in your practice, financial incentives may not actually motivate physician behavior. Physicians will, however, pay attention when we talk about better patient care and efficiencies. And aligning incentives with patient care demonstrates this sensitivity to a physician's needs and their perspectives. And precious as this passion may be for administrators, physician autonomy is actually not synonymous with quality. And for the needed structural and operational changes, things such as performance measurement, process improvements, and teamwork, for these things to become mainstream, physicians need to accept that being all caring is actually different from being all knowing or all controlling. And as a side note, marketplace dynamics are actually not part of a medical curriculum, and I personally believe that a crash course in medical economics would be extremely beneficial to physicians and residents. Physicians generally are unwilling to allocate the time necessary to evolve a consensus decision, and they prefer instead to vote. And then, of course, they wonder why so many fail to comply with the behavior that is expected. In my personal experience, as a side, if you have an individual physician that actively seeks out to be a chief of medical staff, they usually have one sole objective in mind, and that's to have the CEO replaced. So when engaging the physicians in a consultative decision-making, I would suggest that people communicate that you're actually seeking many different options, that you'll consider all the advice that you receive, and communicate your rationale after you've made a decision. In this way, you significantly avoid misunderstanding that might otherwise result. And phrase your vernacular, if you will, not in the sense of what do you think of, but rather what could we do together. An administrator should seek out only the most dedicated physicians for things such as a strategic planning process, because intermittent involvement can be disruptive, and physicians are in a unique position to provide input on things such as systems and strategies that will improve patient care and satisfaction, and allowing administrators to focus on what they do best, which is operational issues. Physicians generally collectively reject all truly new ideas, and they promote change. You must be willing to lead not to consensus, but actually to critical mass. And another tip is, I like to say that don't change things, but pilot everything. And an example would be to say, if this is a good idea, what could we do to bring it about together? And an attitude that first seeks to identify with a physician's needs and then seeks to facilitate their success, this is the foundation for creating this enduring and lasting relationship with your docs. Unfortunately, the physician too often is viewed as someone that can be leveraged to serve your practice's needs, and this only promotes that suspicion that we talked about and erodes some of that essential trust that you're going to need. So to overcome this, emotional resistance, you actually need to address this emotion that's coming from the physicians, and not by continuing to propose your fact-based data and trying to show that the resisting physician that you're actually the one that's correct. You frame your beliefs in such a way that their behavior actually frees the physician from some of these mundane tasks of things like entering orders, and allows them time to perform things for which they are uniquely qualified. And with that, we're going to take my little Marco Rubio break. All right, we're good to go? All right. I'm good. Okay, so let's segue into a little bit about physician recruitment. It's a big deal for medical practices that are dealing with exit strategies, mergers and acquisitions, and even for hospital groups, of course, who are always trying to get bigger. As we know, there's a growing physician shortage that's out there. It's making physician recruiting a top priority, but oftentimes recruiting is just an administrative task. And the problem with recruiting efforts at this level is they become short-circuited by things such as physician dynamics and resource problems, and of course, organizational inertia. So what happens when leadership takes a hands-off approach to physician recruitment? Well, for starters, and the most important one, is we get physician resistance. With their practice base and income at stake, physicians often have a good reason to be suspicious of attempts to bring in new providers. Physicians that are struggling to maybe build their practice, they have a strong incentive not to assist with the recruiting efforts. And in fact, a lot of times medical directors will flat out refuse to cooperate with the recruitment efforts. The other thing we get when there's a hands-off approach to physician in recruitment is, of course, we get inadequate resources. And to be competitive in today's environment, practices need to make a significant financial investment in recruiting in terms of both physician compensation and recruiting tools, and by that I mean things such as physician recruiters. And also a lack of top leadership involvement is going to translate directly into inadequate funding. Where's the beef? Thank you. So the other thing with hands-off approach to physician recruitment is we have this uphill battle to align support throughout your practice. So effective recruiting, actually an effective recruiting program actually depends on the cooperation of everybody throughout your practice, and without top leadership involvement, it's going to become everybody's lowest priority. So the biggest problems occur that when recruiting is just another item on the agenda, and to be successful, it actually needs to include both individual vision and structured accountability. And top leadership, they need to understand in the practice or in a healthcare organization that physician recruitment is key and a critical challenge, and formally communicate to the organization that is a top priority from the very top leadership of that practice. Leaders need to understand and develop for recruiting responsibilities, things such as developing strategic planning goals, of course your short and long-term goals, and develop a formal reporting process for the actual recruiting activities. And this combination of commitment throughout your recruiting process is actually going to help in several different ways, and we'll touch on each one of these four a little bit briefly now. So for starters, strategic support. So one element of strategic support is the readiness to take advantage of partnership opportunities. So let's say, for example, you have a specialty practice, maybe like a radiation oncology practice, that's looking to get with the hospital and collaborate in some sort of shared recruiting goals. Of course, the practice is going to be looking for some sort of financial assistance, and the hospital is going to be looking for some shared staffing. The whole situation in a case like this is going to require high-level negotiations and long-term planning, because without this leadership involvement, the deal simply is not going to go through. In contrast, let's say, for example, you have a multi-specialty practice that refuses to cooperate with the hospital's recruiting goals. Probably sounds familiar in this town. And the hospital CEO makes a difficult decision to actually recruit against the group. If the senior hospital leadership doesn't understand and support this decision, the CEO is quickly going to be out of a job, and the hospital's recruiting goals are actually only going to worsen. So the second way that sustained leadership support can energize your recruiting campaign is actually through economic support. Top leadership involvement, again, I can't stress it enough, is key to building an effective economic platform for your actual recruiting program. And in the coming years, to be successful in bringing on new physicians, it's going to be the ones who invest in significant financial resources in physician recruiting. So what we see in hospitals today, and it's true a lot with as solo groups become small groups, they're negotiating a smaller guaranteed base salary with a higher productivity-based compensation that actually aligns revenue and protects the practice from losses. And in this model, they get rewarded for a certain level of production of work, which is a good baseline, and ties their compensation directly to volume. And make no mistake about it, it will always be about volume. As we go through the three phases of reimbursement, right, fee for service, bundled payment, value-based or outcome-based care, even at the final stage, if you take care of one patient and you're rewarded based off of value and outcomes, and you do a really good job on that one patient, good for you. But if I take care of 5 and do a really good job, I'm the winner. It will always, always be about volume. However, competitive compensation with regards to physician recruitment is only the start. Up-to-date recruiting packages are going to include things such as sign-on bonuses, moving expenses, loan repayment opportunities, startup support, ongoing retention incentives, and professional liability coverage. And in today's difficult real estate market, many physicians will require additional cash to actually cover the sale of an old home or a cost of a bridge loan to actually acquire a new one. So they'd have to develop some sort of organizational support for the recruiting program itself and balance between things such as internal staffing like HR, et cetera, and external resources, again, things like physician recruiters. And high-level decisions are required for advanced options such as these. Another example is profit-sharing arrangements. And to be quite blunt, mid-level managers without the support of top leaderships, they're just not going to be able to marshal the resources in order to actually put together an effective recruiting package. The third way that sustained leadership support can energize a recruiting campaign is through tactical. So for a physician recruiting campaign to be successful, of course, we have to have teamwork from throughout everybody in the practice. And leadership involvement, again, is critical to making things happen. So one key area to look at from the tactical level is the actual candidate interview. So successful practices, they've actually structured a well-organized interview process that ends up in solid hiring decisions on a timely basis and doesn't drag things out. And to create this actual good interview process, you should have evaluation criteria for the physician candidates to use, define decision responsibilities as who's going to do what with regards to that interview process. And as an administrator or a manager, making sure that the physician interviewers actually stick to the decision criteria and of course provide prompt feedback. You also need to make sure that physicians cooperate in actually making the interview a good visit, an experience for the candidates. Visiting physicians should meet with a mix of people from administrators to department chairs, frontline physicians, you name it, throughout the department. And everyone should be prepared to make sure that there was a good visit with a positive attitude and constructive information for the candidates that are coming through the group. And the fourth way that you can energize a recruiting campaign, of course, is through effective planning. Only top leaders, in particular senior medical staff leaders, they're the ones that are going to be overcome staff resistance to the recruiting and the planning process. And keep in mind that physicians near retirement, unfortunately, are famously silent about their plans, leaving administrators to guess as far as their staffing needs and what they're going to be like in the future. And dissatisfied physicians are even worse with regards to what their hidden agendas are and the fact that they don't want to cooperate. And while a certain amount of commitments throughout the extended period demonstrating they don't intend to recruit around a physician, but actually support current staff through temporary volume decline and the adding of new providers. So again, working with the physicians to understand that we're all in this together, if you will. And while a certain amount of pressure is sometimes necessary, physicians do tend to self-police themselves, especially when you have a senior physician that's actually behind the recruiting effort. So ultimately, a strong commitment by top leadership is going to create this culture of recruiting, and that is an organization in which everybody understands the importance of the recruiting process, and everyone cooperates in things such as conceiving and planning and actually executing the effective recruiting program. And as this competition for physicians across the country continues to heat up and organizations become more sophisticated at wooing them, a culture of recruiting actually may be as important as a culture of quality or a culture of financial sustainability. In places where physician recruiting is actually a top-level priority, leadership priority, they're the ones that stand the best chance at building a critical organizational structure. So we are now here in the, come on, no baseball fans? 7th inning stretch. All right, we're good to go? Everybody all right? We're still awake? All right, we're almost done. So despite some various benefits, many physicians, of course, are resistant to various kinds of changes in healthcare. The resistance they feel is they usually kind of base it on 3 things. One would be bad medicine, 2 would be disenfranchisement. Or 3 would simply be what they consider to be bad economics. So what is it that as a manager or even as a vendor or as a professional service person that you can actually do to better exercise or influence and in that process change the physician's behavior? It's not waterboarding. I would not recommend that you waterboard your physicians. But for starters, we have 3 or 4 of these. For starters, we have a bottom-up approach. All physicians that I know, they actually prefer bottom-up approaches as compared to top-down edicts. Remember that autonomy is key for physician cultures, and I don't know of any physician that likes to be told how to take care of their patients. I would also suggest we find the win, if you will, in small projects. And remember, as I said before, that time-wasting efforts frustrate physicians and makes them feel disrespected. So start with small projects and build on quick wins that offer overt benefits to physicians, such as time savings and practice improvements. And when you collaborate with your physicians, start small, focus on the benefits that are involved, and to gain participation from physicians, you have to answer that the tail-old overt benefit, and that is, what's in it for me? It would build on and celebrate your successes at least quarterly. That keeps this momentum going, and actually use word of mouth to promote your ideas and activities instead of constantly coming down from the management, if you will. We also look at things like healthy competition. And this is valuable when administrators are frustrated with the proverbial herding of cats and then trying to obtain a consensus with decisions that come from different backgrounds and different cultures and generations, as we started off today's talk with. The healthy competition method encourages physicians to work towards goals and avoids the frustration of actually asking physicians to agree. And lastly, the infamous physician champion. A physician champion is someone who has earned the respects of their peers, period. It's not the senior physician per se. It's not the one that you like to go golfing with. And it is certainly not the physician that raises their hand and volunteers. If they don't have the respect of their peers as a physician, they will not be able to champion the efforts. And physician champions, of course, would help with change in a variety of ways, such as presenting and discussing clinical data presentations, minimizing physician and administration battles, creating, of course, a safe learning environment, building on transparency and trust between administrators and medical staff. And with that being said, we are indeed done. How about that?
Thank you, Nick. That was great. We have quite a cross-section of people here, so I'm sure we have lots of questions, and we want to make sure that we get all the questions recorded because all of the presentations are archived on the MOROF.net website, and this one will be there as well. But we want to make sure that any of the questions here live is also recorded as well. Anyone have any questions? And I'll get the mic to you before you answer quick.
Dan O'Connell, MOROF ambassador. There's no such thing as a free breakfast. You have to listen to this question. But I loved all your slides. One that struck me in the earlier part was you talked about the problem of failed communication. And I deal in a project that deals with communication silos. And so I want to get your input on the lack of connectedness between different entities in that communication process.
Yeah. Different entities, even outside of a medical practice, you mean? Yeah. So one of the biggest issues that I see is doctors are really busy, and everybody likes to say, yeah, I know that. Well, maybe not. You know, so doctors, they go to school to treat patients and care for patients. That's it, period. They could care less about managing their practice, and to be quite blunt, aren't necessarily that good at it sometimes. And so they're really focused on caring for the patients. So it's not that they don't want to engage with people outside of practice, be it a marketing firm, a consultant, a lawyer, an accountant, what have you, but they're so busy ingrained in there. And that's why I try to tell the physicians that if they, the ones that can actually develop and manage a good, and mentor, I mean, a good practice manager, office manager, administrator, whatever you want to call it, depending on how big it is, there is so much more of their weight than gold to that practice. It's unbelievable. And the physicians that actually do that, they can see that because that type of person, that's their forte. Their forte is not caring for patients. They're not clinical, and if they were a former nurse, they should remember that that means formal. They're there to actually take care of the business, to include communicating with professional vendors outside the organization and bringing back and boil down executive summary for that physician who's actually the physician owner and has to sign off on the checks and makes those decisions. That helps to increase the communication, and not only within the group but with outside agencies, but also helps to keep the project rolling. So for those of us that are not actually working inside a medical practice, for those on the outside, those are the kind of places that you really kind of hone in. Keeping in mind, of course, that in a physician practice, you're going to have, it's most likely not going to have a manager who's a shareholder, if you will, who has an ownership stake. It's probably going to be one or several of the physicians as their partners. But the one who can really help you to move your project along or advance your agenda is going to be that particular manager that's there. Those are the ones that are key, even though the doc is the one ultimately making the business call.
Good morning. I'm Kurt Reed with Cho Cryosauna, and that's cryotherapy with that helps with all natural health for a variety of issues. We have a program to where we go around to doctors to educate them on what cryotherapy is and to provide them an alternative to medication or other treatments. And we've had a kind of resistance, I guess. We have a script program and we have an education program. We go around to lunches and stuff. But it seems to be resistance of supporting an all-natural health arena. What suggestions do you have that would help us get into those kind of environments to get the client or the patient treated all naturally?
Resistance, you're having issues getting an audience, or resistance to having them accept the idea of the cryotherapy?
I don't know what it is, but I do know we're not getting the clients from their practice to help with the treatments.
Yeah. So this may or may not answer the questions, but there's a few things that may hinge off of this, and then perhaps some other things that people may be thinking about. So doctors don't trust anybody. Certainly don't trust business people like myself. They definitely do not trust administrators, especially in a hospital environment. But if they're going to trust anybody, it would be another doctor. So a couple of things for starters. Unfortunately, with the way that the economic pressures and the reimbursement has put on, a lot of doctors don't have the time anymore to get involved in things like county medical societies or even some state medical societies, not only from their time commitment, but also from a financial commitment. So they've actually cut back on a lot of that. And unfortunately, there's a few ways to try to get around it, if you will, as far as getting that audience. And that's to try to get into some of those places where they still actually do congregate. You oftentimes have a better chance of getting some time with a doctor than the ones that try to go and do lunches at a particular clinic. For those of us that have been there before, you know that trying to see a doctor on clinic day, of course they'd love to have you come in because you're bringing free lunch, but you don't get much time with the actual, especially on a clinical thing like you're talking about, for those key decision makers. At best, hopefully you're going to hit it on a day where maybe there's a nurse manager or something like that that you can actually explain it to. But where I was going on the first part is that if you have the ability to get to a place where they do congregate, again, there are some county medical societies that are still good, of course, states or trade shows. Now when you get other doctors that are there that are actually talking about your product from a clinical standpoint, this is where you can get to, as I mentioned earlier, a more of a critical mass of people that are actually starting to use it. Doctors using your thing are going to be your best sales advocates and not other consultants or people like that, once they've used it and to gain it that way.
Hello, Jeff Holt with PNC Bank's Healthcare Business Banking, and it's great to be back and healthy again. So it's nice to see you all here, and after several months of recuperating here. So anyways, good presentation. Question is implementation of technology to a physician that's resistant, what do you feel, what might be best practices in order to get them comfortable and up to speed with utilizing today's technology?
Yeah, so that's difficult. So if you have a solo practice or a small group that has older physicians, that's the biggest challenge. So let's talk about the easier one first. If you happen to have a small group that actually has some younger physicians, if you will, that are more comfortable with technology, those are the ones that you can kind of help to, from a physician champion, if you will, to try to move things along a little bit. So a lot of times you go into a small practice and a lot of these staff, the non-physician staff, may actually be comfortable with technology. And so as some of the younger physicians. Starting that way to adopt things, and it could be a variety of platforms. It's EMR, it could be just billing systems, it could be things like telemedicine platforms, et cetera. With some of the older physicians, if they're just by themselves, I don't have a good answer for you for that. I've talked to a lot of physicians that may be a solo type personnel. They maybe thought that they decided to get into EMR because it was forced. Some of them have literally scrapped it, the entire investment, and gone back to paper charts, the proverbial middle finger to Uncle Sam. And I don't really see a way around it. And I think, to be honest, that kind of thing shows me a little bit more about how you can't have these top-down edicts to physicians. If the physicians were taking good care of themselves, I'm going to get on my technological soapbox here in a minute, but I'll get down. But so that if the physicians are taking good care of their patients and with paper charts, and the government said we're going to have electronic medical records, and then they said electronic health records, and there's no such thing as electronic health record. Case in point, none of you guys, none of your doctors share information electronically with everybody else, so there's no such thing as electronic health record. And it failed. It failed miserably. And we see, even if you read, even big hospitals and groups themselves are all changing their EMR platform after the first 3 to 5 years because they weren't happy with that particular type of technology. You can lead a horse to water, but you can't make him drink. So again, I would start on some of those places, even if it's a solo doc. If you have some staff that's in there that is comfortable with technology, they're going to be the best advocates, not an IT vendor that comes in and says, this is the greatest copier machine since sliced bread, and if you just push this button, doc, it'll do everything for you like that. It's going to have to be someone else that does it, because the other problem is that the staff that's there, they're there on a daily basis. So to pick on an EMR vendor comes in, they sell them all these whistles and bells, and they're there for about 2 days worth of training, and then they leave, period. Well, the doc, as you can imagine, is a little frustrated, and who has to deal with it on a daily basis? It's the rest of the staff that have to deal with the doc on the bad hair days 5 days a week, and even sometimes after hours. So really the best way to do it is to try to get, again, the critical mass, is to try to get, or from a champion standpoint, if you have the other physicians, but I mean as a solo physician, get that staff on board, because they're the ones that are going to be able to advocate not only for the initial implementation of technology, but also to make sure that it's efficient, that it's up and running, so that down the road, you as the IT vendor aren't the ones that get bad-mouthed because it was a bad product, when in fact it just wasn't adopted well because you were in and out and the staff didn't know what to do and they couldn't really usher the change.
Any other questions?
Martin Forster, Pharmanex. Excellent presentation, thank you. I would like to understand how it is you propose to get the staff on board when the staff are already overworked and the last thing they want is extra work.
Yeah. On board with?
Anything new?
Yeah. So, well, some of it is mandated, right? So, not to rub salt in the wound, but we could be talking about ICD-10 when there isn't any other idea, or there isn't any other option. So it really kind of depends on what it is that we're talking about. So let's start from the physician component. So sometimes a physician will actually see something at a trade show, they read about it, and the physician owner, and they actually want to implement this in the practice. Well, that's the age-old thing of the boss wanting to do it, and you can either make it happen or you can find a new job from that standpoint. So kind of get on the wagon, if you will. But other times there are things, even as the managers, I think is really what you're talking about from that standpoint. The staff is looking at maybe implementing new ideas, and how do they actually do that when they're so busy. So a lot of times what you see is that staff usually will have kind of one or two kind of pet projects. It's best that I tell them not to try to start too much at once, because there are so many things going on from a time component. There's also a very limited budget that the physician group is actually going to allow to happen. So some of this starts, for those that have formal budgets, to toot the CPA guys' horns in the house, that they should actually formalize this budget at the end of the year to include this strategic planning process, if you will, as what's going to be rolled out. So it doesn't seem overwhelming to all the staff. So here we are, we're going to implement this another thing, and then next month we got all these balls thrown at us at once, let's say in January, and come May or June, everything's off the table, and the crazy doc just spent a whole bunch of money on nothing that ever amounted to anything. Where if they plan these projects out, whatever it is that you actually want to implement in the change, you have a much higher adoption rate and a much higher success rate of implementing certain programs. Again, now, some of the things that you'll have to do are going to be mandated by law. It could be ICD-10 or meaningful use or whatever is coming down the line. Those have to be planned in as well, and obviously those sort of things with regulatory compliance are going to take a top priority, and right behind that are going to be the physician owners' pet projects, if you will, and then right behind that, as the employee, are going to be things that you would like to initiate change. And sometimes they can even start out in a certain subset of the particular practice. It may be in a practice, in a certain department. It may be under a certain treatment modality. We're just going to be a dermatologist. We're going to make a change with regards to how we solicit referrals for Mohs surgery. And eventually we may expand that into aesthetics and Botox and what have you like that. But starting in these small places, that's the best way without having the staff become overwhelmed by all the stuff that gets thrown at them at once.
Thanks for the presentation, Nick. It was really, I liked it a lot. Great. I have a question. So I'm with All's Well. We do recruiting. And I wondered, can you elaborate a little bit?
Oh, I bet you love that plug then, huh?
Yeah.
You're welcome.
Thank you. I was taking notes like crazy. Can you elaborate a little on the bottom-up approach?
On the bottom-up approach with regards to?
With regards to recruiting and physicians?
Yeah, so, huh? I'm sorry, that last part, what?
Oh, I said with regards to your slides and recruiting?
Yeah, so with regards to a bottom-up approach, actually, when it comes to physician recruiting, what I mean is that sometimes you get, let's talk about two. I know we're mostly talking about private practice here, but in a hospital environment where you have the C-suite that tries to push things down on the physicians or the actual departments, and it doesn't go over well. The same thing happens, and I'll explain why. The same thing happens in more of a larger type group, where if you have an administrator and maybe like senior physician or the partners like that, they may actually want to do and push down how the recruiting is going to be done. When in reality, the people in the trenches may understand better what type of, when I say physician, a provider, it could be, a nurse practitioner or a PA that are becoming more popular now in use, so any type of provider. Whereas the people in the trenches, if you will, may understand better. So let's talk about private practice. A lot of times you may have, let's say, and it's all about profiling. I'm a huge believer when it comes to physician recruitment that it is about profiling. So we have, for example, an oncology practice, you have 2 male physicians, and they're going to hire a 3rd physician. And they, for whatever reason, it may not be a sexist thing, but they're just looking and they say, hey, we like this Dr. John, and this Dr. Robert, and this Dr. Bob. But in reality, the nurses and the lady at the front desk that's taking the referrals, the number one thing that they hear from their OBGYN referral people is, oh, you don't have a woman physician. Or the breast surgeon, you don't have a woman physician, so we're going to send them to the other group because the female patient is more comfortable with a female physician. So a bottom-up approach would be soliciting that input from people, in this particular case, from a profiling, and Sometimes it has to do with ethnic cultures as well. You guys don't have anybody that oblas, so we're going to send them to the person across the town. Those are the kind of things that a lot of times the physicians of a top-down, in this case we're talking about docs in a small group practice, they may be looking at a CV and maybe someone is really qualified, but from a growth strategy standpoint, it may be better to look at still somebody that's qualified, but maybe we profile and look at sex and culture and those kind of things that the people that are working in the practice, talking to the staff at the referring physician office, knows why we're not getting referrals. It's not because we do a bad job, it's because you really don't have a good fit for our particular type of patients. So there's a couple examples of what I mean by that.
These are great questions. Any one last question that anyone has? Otherwise, I think we'll wrap it up. Thank you again, Nick. Let's give him a hand.